Arun, and thank you everyone for joining us again. Hope everyone is safe and doing well in terms of their health and this current COVID situation. So today, last week we heard from Brother Swarup regarding not particularly colostomy, but stoma care with more attention to colostomy. Today, another very important topic is subcutaneous injections and infusions, because that is one route of administration of medications that is very commonly practiced in palliative care, and very easy technique for the caregivers per se to manage at home. So it's really important. I know that that sounds quite unfamiliar for many people when you say subcutaneous injections and infusions. Is there anyone in this group who has seen, heard, not heard about this topic, who have seen or given, not heard? Only the theory part we have heard. You can type so that Swarup will also get an idea about their understanding also. Yeah, so we have had an introduction about Swarup last week, so I'm not wasting time on that. So I'll hand over to Swarup for your session.
Yeah, thank you, madam. So very nice to see you this afternoon. And so I welcome you all. I hope you're having a very good time in all these sessions. So all the best for you, everyone. So so in the given topic today, I'm going to discuss brief about the subcutaneous medications and how to administer the medications in that particular route. And I'm sure that many of them are not familiar with that, because it's all my experience when I see a new nurse or the doctor coming up to the hospital for the training in our centers. I see a lot of people are not so familiar with the administration of medications through the subcutaneous route. Overall, before I start my session, I would like to just introduce about how things go on here. Most of us, when we get trained, we are not sure about the subcutaneous injections, and we only know that however is possible, we try to go involve and give a good care to the patient. Overall, that is a main motto of every one of our the health professionals. But somewhere when you talk about the patients in palliative care, which is different, so the general medicine is completely different from the palliative medicine. That's what I can understand in this situation. So maybe in this session, you're going to learn more about what exactly the subcutaneous route is all about, and what are the drugs to be given through that, and how advantageous is it going to be, and what are the drugs to be given together. There are a few things which we may have to learn before treating such patients through the subcutaneous infusions or the injections too. I'm going to share my slide right now. Okay, so here we go. I would like to start with the case history before I start my session. So remember one thing: whenever you present any such kind of topics in your daily works, or maybe with your teams or any of your colleagues, start talking more about the questioning yourself first. Make a big reflection on how did that experience made you to come back to this situation. So maybe using a subject or the history or the case reflections may help you a lot before, because that is a way we have to learn in palliative care. So every time the patient themselves gives you a lot of information instead of all your research and evidence based practices. So I would like to start with the case history, and let us see. There is a patient who was diagnosed with the carcinoma of the right breast with the infected wound and also the lung metastasis. So I see her performance, her activities based on the disease condition, appetite, oral intake, and level of consciousness. It is 20%, which is very poor, very low, and she's about to be in a state where she's completely dependable and experiencing severe pain in the chest, breathlessness, and anxious too. So severe pain, breathlessness, and anxious. So this is a brief history of the physical symptoms what the patient has been experiencing. Apart from that, there is a poor family background, and as I said earlier, they even reside in the remote areas. So very poor background, family background. So how can we help this patient and family in their suffering? Right now, our goal is just about the controlling the symptoms now, nor educating the family as they live in the remote areas. So they are from a very poor financial background where you may need have techniques which are more easy and comfortable for the patient and family to do it. How can we help them, patient and the family? So this is what the question should rise for every one of you when you're treating the patient. Don't just use your technology nor your hospital setup, but somewhere I feel that you may have to use the situations how it demands at the home. So if the situations are worst at home and there is no resources available, you may have to go into that and think about it in a different way. So what health education can be provided? So health education plays a major role in administering any kind of medications, not the subcutaneous. So how are we going to deal with that? How do we educate the patient and the family? How do we provide a good quality care and comfortable comfort during her end of life care? So this is a main point where I concentrate on. We know that the patients with the performance of 20, it just means that they are not doing well and they're going to die soon. And maybe the preparing the family, nor the patient is all important. Apart from that, providing a good quality and the comfort comes up only when the physical symptoms are a bit under control. To make the patient more comfortable, what are we going to do and what is our achievement? And are we going to provide a good quality care in this patient? So this is what we're going to learn today about the subcutaneous. A brief about what subcutaneous infusion is all about. So number one, it is an alternative route to the intravenous or intramuscular, which is called as a subcutaneous injections, or it is also called as a hypodermoclysis, HD and C. A subcutaneous injection is administered as a bolus into the layer of the skin is directly below the dermis and the epidermis. So this is a sites where we may have to introduce the drug directly in. So it is highly effective and suitable alternative in administering the medications. So a lot of medications or the medicines what we administer in palliative care are more easy access to the subcutaneous route. So instead of preferring the routes which are a bit complicated, like intravenous or intramuscular, which makes more painful even in the future. So to prevent that, the subcutaneous route is more safer, and most of the drugs and palliative care also can be given through this route. So this is one type of butterfly wing set needle. We call it as a butterfly needle, which has a steel coated layer at the top, the needle, followed with the wings on the both sides, and a set, so which is around some approximately 10 centimeter length. So this is one of a type of needle which can be, we call it as a port. Port is nothing but when any needle or a cannula which is placed in particular area for a longer period of time, we call it as a subcutaneous port. So this butterfly wing set needle is going to be introduced directly into the subcutaneous tissue directly, and it can be fixed up there for a period of time. So the drug can be given, just have a look at this. The drug can be given through this opening. So it can be opened and the drug can be pushed into this, where the whole tubing may carry approximately 2 ml of the injection. So once you start pushing the drug into this directly, approximately think about you're going to introduce 2 ml of, for example, a ketorolac injection, so which is for pain. Not think about for vomiting, you're going to introduce metoclopramide, that is Perinom, 2 ml. So 2 ml of drug, when you introduce into that, approximately more than 1 ml is going to stay back in this IV set. So after this, you may have to push some normal saline or water for injection. So the drug can enter directly into the needle and the water may remain in the tubing. So this is a type of, I just wanted to show you how what we use. And only one disadvantage with that is maybe as the needle might not be in place all the time, so it may leads to further damage. So we don't even prefer that. We have another type of cannula, which is a 26 gauged cannula. We generally use it for the pediatric patients. So yellow colored, where once, just like a cannula, we just insert in and the plastic coating over that will remain into the skin and the needle may come out. So once you just take it off, there will be no punctures or any extravasation or injuries locally in that particular area. So this is more preferable. Just like AV cannula, you have to just use a easy fix to that area and cover it well. So the patient might not feel like there is a needle inside, and they'll not worry about that. So a lot of education, that's what I'm keep on telling again and again, a lot of education. So it all just means that when you start talking to the patient about how it is going to be, we may have to explore telling them that, okay, these are the good things that are going to happen when you have this. These are the worst possible things you may have if you're putting on this. So when you talk about the good and bad, it is nothing but you're going to give a decision making opportunity for the patient and family to do that. Most probably anywhere in the hospitals, they don't do it. So it is all just a one-to-one conversation with the family, and they just leave it like that. So that's the reason why when you have a very poor communication, it all happens. So when you start talking to them and telling them that, so I'm sure that most of the people will be scared of using these cannulas in a different route. As most probably, I see a lot of our nurses and doctors who come here for training in our center. Once they look into that, they feel like it is a bit different. Is it so important? Why can't we go for the IV route? So when you talk about that, there are good advantages in administering or fixing this kind of subcutaneous port. So when you talk about that, only the people can really come to know about what it is all about. And this is a drive fixed to the IV tubing. So this is a so you can see in the green cloth I have a infusion pump. It's a portable infusion pump. So this pump can carry approximately 50 ml of normal injections can be fixed. So you can see the syringe out here and the outlet opening. I have connected a small IV set. I've taken some 12 centimeter IV set at the bottom end. So this end is going to be fixed directly into the butterfly needle nor the IV cannula, whoever it is. So the whole pipe or this tubing should be filled with the injection, and it can be given. So approximately this is a type of a syringe drive where you can administer huge quantity of drugs directly into the body. So we'll see the benefits and the disadvantages of that. This is what. So earlier the green cloth was closed and I've opened it. So have a look at this. This is a type of a continuous, it is called as a continuous subcutaneous syringe drive. So it's nothing but the advantages I see in this continuous subcutaneous syringe drive is the drug can be entered into the body in a proper intervals. So think about it. You don't have this subcutaneous infusion with you right now, and there is a patient suffering a lot in breathlessness and anxiety. It's not even sleeping at all. The whole night he was panicked and worried. So I don't think the regular fixed doses of intervals of the injections may really help them in that situation. So we have the continuous subcutaneous syringe drive. So this is very portable. This can be fixed anywhere very close to the body, and it runs with the battery. So it doesn't really need any power supply for that. So the patient even can carry this out to the washroom or to move out from one place to the other place. So anytime he wants, he can just stop it just like that. And the whole drug can be moved into this. Have a look at the syringe out here, and you can see there is a small written format here. So these are all the mixture of drugs, like we have injection morphine, injection midazolam, all things you have written in here is with the capital letters. So remember that something that which is very important. And we also have a haloperidol. See here we can see the 3 drug compatibility: morphine, midazolam, and haloperidol for the different types of reasons. Earlier, when you go back for the history of the patient, you can see the patient is with a lot of pain, chest pain, breathlessness, and anxiety, and a bit confused. So maybe to control those symptoms and improve the quality in their PPS of 20%, we are administering all this 3 drug compatibility format has been used in this patient. So mixing all these drugs together with the speed of 45 mm to run in 24 hours or 50 mm to run in 24 hours, we have fixed it, and the whole drug moves out in a given time in 24 hours, not even in 12 hours. I can just fix this 24 hours to 12 hours even to have a rapid action, and so that we'll see how the drug has been working in. So the whole fluid or the medication will run through this end into the cannula. It is absorbed from the body through the subcutaneous route. So this is the best I can say, because there will be no fluctuating administration of medications again and again. Once you start, fix it, put a speed, and the whole medicine drug runs for next given time. Maybe it would be 6 hours, nor the 12 hours, nor the 24 hours. So most probably we prefer only for 12 hours, because every 12 hours we need to assess and check for the condition of the status. Number one, talking about the level of the sedation, how good, how bad the condition is going to be. Number two, the vitals are also has been checked, and the level of consciousness has also been checked in this. So based on that, we go for this, and we never call it as a sedation. I'm not even using that word, palliative sedation. So once the symptoms are not under control, we just skip up. Instead of going for the oral route, we just skip up to the IV route. So this is what I have learned when I've been in Canada for a period of time. I see when the patients were not, symptoms were not under control with the regular medications, the oral medication, they just skip up to the injection form, observe for a day, and then they come back to the normal routine form. So where they wanted to see is the good quality and comfort. They don't delay. They don't delay the time and wait for one more day to start on the other routes of medication. So stacking of the morphine is more important, or any kind of drugs. So once the patient is a bit comfortable with that, so he can just skip up to that level. So subcutaneous syringe drive is also helpful for range of severe pain. Number two, the patients who is breathlessness, like in the history, we have seen a patient with the pain as well as breathlessness. So, and the patients with the intractable vomitings who can't take any oral medications, and patients really could not take any oral medications. For example, there is a patient with who was on 10 mg of oral morphine till yesterday. All of a sudden, there were a lot of changes in his body, and he became semi-conscious. So it doesn't just mean that he's in semi-conscious state and he doesn't require pain management, but he has to take that pain medications in a given regular intervals in a different route. So when there is no oral route, we can go for the subcutaneous infusion or the subcutaneous every 4th hourly, based on the symptoms which are persisting. So that's how we do. This is called as a subcutaneous route. So the question is, why do we give the subcutaneous injections? Why can't the IV? Why can't the intramuscular route? That's what the question is. So IV, when you talk about the IV route of injections, it is a bit hard for even the staff to get the IV cannula done. I see a lot of patients in our hospital who are undergoing the chemotherapy and the radiation. They develop a lot of excoriations, multiple punctures, and it is a kind of procedural pain I see. Even in the small kids who are suffering with the blood cancers like AML or relapsed AML cases, I see the disfigurement and a lot of patches all over the body. It is just because of the procedural pains. And most of the people are scared of getting the injections even. So do not try to involve some technology into that, but just think about what exactly the patient they require. So when you talk about that, all the drugs which are available in the palliative care has an option of giving, instead of IV, we also have another route called as a subcutaneous route. So where all these are the safest medications which can be given in that route. So let us see that. Why do we give subcutaneous route instead of the IV nor the IM? IM is more painful again, and a lot of drugs which are given through the IV, the patients may develop a lot of mass in that particular areas, and it may lead to a lot of pain again. So in the future, the patient has to suffer a lot with this intramuscular injections. That is more painful when compared to the IV and other routes. IV, a lot of prone to get more infections if the days have been prolonged. So maybe 3 to 4 days, every 4th or 5th day, you may have to change the IV cannula. Instead, which is the best route and safer. Let us think about that. It can be given many types of medications. It can be used to give many types of medications for various medical regions. Like subcutaneous is safer and most probably more helpful for the patient. Patients who cannot take oral medications and who are semi-conscious state. Also, I would like to add the patients with the intractable vomitings. There is a patient with who is with the case of intestinal cancer. Just think about it as a CA colon with the omental metastasis. Or you know that omental metastasis is somewhere the patients may develop constipation alternative to the vomitings. So all the time, the nausea and the vomiting remains all the time. So one day the patient also developed the fecal vomitings and he's in a lot of pain, a colicky pain in the abdomen. So when he's really in pain, there should be an alternate route of administering the medication. So we prefer the subcutaneous route, which is more helpful, and the drug enters into the body and the symptoms will be more in the control. So overall, we are going to view or look into that is providing a good quality care in controlling or the managing the symptoms, and showing the patient that I'm there to support you, and we are not going to add some more technology to that, with which the technology, a lot of the chemotherapy, radiation itself can lead to a lot of side effects with which the patient may not be able to cope up with that. So if that is how the situation and the patient really is in a bad state, never ever try that. That's what we say. So trying that and the patient's performance may come down just because of the side effects. So we don't even prefer that. So instead of using a technology, just talk to them, tell them what is good and what is bad. So the third point is it helps to have a continuous flow of medications and it avoids the delay. So the last point I would like to add in this is drugs with the 3 compatibility can be given through this route. Like earlier we have seen in the syringe drive, I have mentioned the morphine combined with the midazolam as well as the haloperidol. So this is a 3 drug compatibility where these 3 drugs can be mixed together and given up. So apart from that, when you talk about the IV route, which is more fast acting than the subcutaneous, a bit faster than that, but somewhere patients with the semi-conscious state are unable to cope up with the situations. So why do we trouble them giving the IV route of morphine, which is double time concentrated, and the patient may have a lot of effect on that. So to prevent that, in palliative care, we use it as a subcutaneous route. So in a 1:2 ratio concentration, we provide that medication. So what drugs can be given in this route is, so most of the drugs which are given in palliative care, like dexamethasone, perinom, ranitidine, and metoclopramide, ketorolac, paracetamol can also be given through that. So there are a lot of drugs which are given through that route. So drugs in the powder form are not recommended in this route because the powder will not be dissolved under the subcutaneous route. So it might be dissolved in the water for injection, but I have another session on maybe in the future we'll look into that. So there is a drug compatibility where I have prepared it. So all the drugs, which are the drugs to be prepared, should be combined together, and which are the drugs should not be combined together. So drugs in a powder form are not recommended in this route because so it gets deposited under the skin, which may leads to a lot of inflammation, and you see a lot of skin excoriations around the skin. So to prevent that, we don't prefer those drugs which are in the powder form, like pantoprazole and any kind of antibiotics which are in the powder form will not be dissolved in that. And also, before you administer any kind of drugs, check the pH level of the drug. So is it acidic? Is it in the acidic form or alkaline form? So every drug has its own alkaline and acidic forms. So before administering, check for that. And there are few drugs which are of oil preparation. Few are preferred, like paracetamol can be given, and the ketorolac can be given through the subcutaneous. Not the diclofenac, which is more painful if it is given through the subcutaneous. So we don't prefer that. So pH level of the drug is also been also very important, including the IV fluids like normal saline, ringer lactate is also preferable, and 5% dextrose are also given through this route. This is a good advantage, and these are the 2 and 3 drug compatibility has to be checked before administering the drugs. This is what I wanted to add in this situation. So which conditions do we prefer? Like earlier I said that patients experiencing intractable vomitings. So when there is a patient who is experiencing a lot of vomitings, not just the nausea, but the patient is expelling everything out, that is called as a vomiting, or the patient may have retching all the time. So maybe he doesn't have the content coming out, but he has an action been repeating again and again. So the drug which is given orally might not help for these situations. So we call it as a retching. So maybe not just the nausea, but somewhere vomiting and the retching, the patient may have to be a bit cautious and convert from the oral route to the other route. Other routes we have IV, IM, which have a lot of side effects and more painful. So when compared to that, subcutaneous route is safer and long acting. So long time you can have this subcutaneous medications under control. So next is it is helpful in controlling the pain and could not tolerate oral medications. Like I said before, I have seen the same thing in Canada when there is a patient with oral medications which are not under control. In the next given 6 hours, the patient's whole drug pattern will be changed into the other route. They skip up to IV, not the subcutaneous route. So skipping up to the subcutaneous route, the ratio will be different. Somewhere 1:2, so double the doses of morphine, or 1:2 ratio. So based on that, the pain is better under control with the subcutaneous route when compared to the oral routes. So they just give a time of period of 12 hours. Meanwhile, the pain or the symptoms, once it is under control, they skip up to the normal level away. That means when the patients who are in severe pain and on oral medications and the pain is not under control, you may have to prefer this route of administering medications in a other ways. Next is about the semi-comatose state. Patients who really are in a bad stage, we know that as the patient's performance, I can say below 30 is nothing but the patient's condition is going to be a bit bad day by day, and they're going to die soon even. So a lot of things to be done at that time. But the one who is in the semi-comatose state or the end of life state, you may have to hydrate them. This is one challenge. So number 2 is about the symptom control. Symptom control and hydration as a lifeline has to be given to the patient. So somewhere I have to stop here and think about the ethical principles. So whether is it good option for the patient, or are we going to do the justice? When you talk about that, there are a lot of patients in our centers keep asking for the fluids even in the end of life. See, there are some challenges you may face about the ethical principles, the autonomy, justice, non-maleficence, and last thing, and beneficiary. So when you think about that, we may have to have a protocol or a plan of that. It may take a long time. So all of a sudden, the patients may come with in a breathlessness state in the last stage of their life, and we can't say that we don't have oxygen available. But somewhere we may have to put that and show them that it is not going to be beneficial. As the same, the hydration and end of life hydration and symptom control plays a major role in that. So you can't refuse that. We are not going to put the IV fluids in the end of life. But somewhere, only thing we have to remember is put it for today, observe for that particular day, tell the family that did we see any change after the hydration. So I feel that it is not going to be worthy. It is not going to help him. Other side, patient is not asking that. We are more worried. It is all about your. So you may have to cope up to that. So a lot of things I would like to add some points to that. That's it. So even in the semi-conscious state, the symptom control plays a major role, and hydration also. The lifeline drugs also can be preferred at this particular time. Number 4 is uncontrolled breathlessness. There is a patient with a lot of breathlessness and panic and fear of death, and he just have a feeling that I'm going to die soon. So where is the quality? Are we providing the quality in this time? Yes. So when you want to provide a quality, you may have to have a good conversation to the patient, and a good support that we are there to help you. So we are here to help you controlling your problems right now. So we are trying to do that. So the uncontrolled breathlessness, so which is making the patient more panic and worried. So subcutaneous route is more preferred at that time. And few situations where there is a subacute intestinal obstructions, fecal vomitings coming out, which is very disgusting for everyone to think about it. Even there is a patient with intestinal obstructions and the stool coming out from the mouth. So never ever no one think about it even. So no one likes to even think about that. So stool coming out from the mouth, a disgusting taste and the smell, which makes them more uncomfortable, and which is a bit hard for everyone. I can say that they are in the type of curse even. Many people feel that. So when I had an interview with few patients, like, how do you feel? And so when the fecal vomitings is coming out from the mouth, so how do you feel? So they feel that instead of this kind of life, the death would have made me more comfortable instead. So these are the problems where we may have to look into. So subacute intestinal obstructions or the complete or partial obstructions, the subcutaneous routes can be preferred. So benefits associated with the pain management is, so can be used in patients with the poor venous access. Number 2, provide a good pain relief for the patients who are unable to tolerate oral medications. So like we see, allows patients greater mobility. So when you give a good, comfortable symptom control, when the patient is more comfortable, it improves the mobility of the patient. So the onset of action takes approximately 15 to 20 minutes. So maybe you can see the change in a rapid form. Sometimes even patients may feel that it is all the placebo effect. So it's apart from our discussion now. So actually it may take approximately 10 to 20 minutes for the drug to work on. So costs almost half of associated with IV infusion. When you talk about the IV, you need a nurse to administer the drugs in time. So, or you have to load it up, and the the blood coming out through that, you may have to be a bit cautious about using the IV infusions. So to prevent to prevent that, we are in the position where to think about, like earlier even I spoke to you about the cost in the session in the history. So patient's condition is becoming bad day by day, and their financial status is making the financial. Just a minute, please. Just 1 minute. Madam, I'm in a session. Madam, can I call you for 10-15 minutes? Yes. I'm sorry. So the costs are almost half of that associated with the IV infusions instead. So this is one point I would like to say. So things to watch for is use a small gauge winged butterfly needle with short length. So small gauge winged butterfly with the small short length. So site selection depends on the patient's activity level and type of medications delivered, and avoid sites where the tubing of the pump could be disturbed. So it should be in a place where it should be free and flexible. So site should be free from irritation and away from the bony prominence and the waistline. So these are the points we may have to remember. So things to watch for. And so report complications like if there is any leakage in that area, redness is identified, and the discomfort at the insertion site. And maybe sometimes it would also be painful when you administer medications through that route. If there is any level of minor level of injuries in that areas, it also may leads to a lot of pain. So when there is pain, leakage, and redness and discomfort, we may have to think about that. So this is what we may have to look into. And in continued, so on subcutaneous hydration, watch for the local swelling and minimize the flow. So as I said that even the fluids also can be given through that. So subcutaneous hydration, when you see localized swelling in that area, you may have to regulate the flow of the fluid levels. That is what you can do. So based on the swelling, it should be in a balanced manner. And number point 2 is a patient and the family has to be explained about the route of administration. Just like an IV cannula, the family might be requesting or calling any of the medical professionals all the time. Now you see the nurses plays a major role in caring of many patients who are affected with the COVID. So every time it plays a major role. When the family is more early introducing the information to the family, that's what the states, state of Telangana, in all the states were doing it. So when somebody is affected with that, they wanted to undergo the family members to train more in that and get a good health education and try to implement those things at home. It achieved a lot to say. As the same, the patient and the family has to be explained more about the routes of the route of administering the medications. So one day they have to take that responsibility in going forward in administering medications. So check for the patient's response to the medications, the administered medications. Check for the response. If there is no good response and still you're administering the medications in a given time, that would be perfect. But somewhere the symptoms like breathlessness, pain are not under control. For example, out of 100%, the patient is experiencing 70% of pain still when the patient is on the subcutaneous medications. So one way you may have to look into that is it should be a challenging case for you, which means that you may have to be a bit cautious, and the pain is or the breathlessness is a major important plan in controlling the symptoms. So if you try to control that pain and the breathlessness to a good level, which means that you have achieved. So patient's response to the medication also has to be checked. Check the device and its battery power. When you're using the continuous infusion, check the battery and its power. Keep changing the batteries, or if it is of the power supply, so check for the connections well. So check for the precipitations and crystallizations in the syringe. When you are loading the drugs, don't ever just try to load and if there is any compatibility, don't just leave it like that and go and administer, which may lead to a lot of complications in the future for the patient. So check for the precipitations, check for the crystals forming in the syringes. So you have to be a bit cautious about that. Approximately 1500 ml for 24 hours of fluid can be administered through the subcutaneous route. We call it as a lifeline. And so the hydration can also be given through that route. How to regulate that is on the first point, you can see the subcutaneous hydration. Watch for the local swelling. Based on that, you have to minimize the flow. So equipments required to fix the port. Number 1, the clean gloves, alcohol swab, antibacterial skin preparation. I'm going to show you a small video about how to introduce that. I hope that is going to be helpful for you. And a small 26 gauge IV catheter, medications in appropriate syringe and a container, and medications administration record. So what are the drugs we are going to administer? Like earlier in the picture you have seen, the nurse has written in a clear form the capital letters and its dosage and how drugs are being mixed together. How do we run those syringe drives? So the medication administration record plays a major important and good documentation, we call it as. So there are a few points to remember in that. Use infusion pump every 12th hourly. This is my request to everyone. So 12 hourly, why are we going to do that 12 hourly? Because so using the infusion pump 12 hourly, for the next rest 12 hours or the existing 12 hours, you can see the response of the patient. For example, the patient's breathlessness and pain is severe before you start the infusion pump. And in this 12 hours, when you run the drugs in a given time, if they feel that patient's symptoms are up to the mark, not completely, at the moderate extent, symptoms are controlled to the moderate extent, that means that you may have to increase the doses of medicines. So to increase the dose or reduce the dose, if the patient is a bit drowsy within the 12 hours, you can't go up adding the doses again and again as the same. You may have to come down or increase the doses based on the symptom control. The achievement of in this is in the end of the life, in their last given few days, maybe we are going to provide a good quality and dignity during the death. So remember that that is the only point where we are going to stop here. So the symptoms and adding drugs if required. So the nurses charts on symptom severity and documentation. I don't have a picture of that to show you. So as I told you that the patient is in breathlessness and pain and anxiety and worried, sleeplessness, I'm going to chart it in a paper, nurses documentation sheet. Every 2 hourly, the nurses keep, whoever is on infusion pump, the nurses go every 2 hourly, check for the symptom control. For next 6 hours, still the patient's breathlessness is not under control, you may have to take an action in changing the given drugs. So till the time when symptoms are under control, and also that gives you a good documentation in presenting to somebody. When the other day, when you talk about, see, in my experience, we call it as a reflection. Oh, in my experience, there is a patient with a lot of breathlessness. I have put on these compatible drugs together, and the symptoms are a bit under control. And slowly, I have converted into the other route. When you have this documentation, it is a good evidence for maybe your colleagues, not the new nurses who are coming to you, get trained up there. So that gives a lot of information, and it will be good platform for you to improve yourself. So care plan preparations. So what are we going to do when the patient's condition is bad? The nurses doesn't just mean that we are here only to administer medications. The nurses plays a major role in palliative care, where they are the decision creators or the leaders in the palliative care. So overall, I see there are a lot of people in the other states where I've been to, the other parts of the country or the other countries too. I see the nurses plays a different and a major role in controlling the patient's symptoms, as well as the sharing the information to them. So I hope everyone who have joined here today will be in that level one day. I really expect that from you. So good care plan preparation and the team discussion. For example, the same case history I'm going to apply to every one of you. What have you learned in that? Question number one. What are the different things you have tried in controlling the symptoms? How good the patient's symptoms were under control? These are the 3 points which have to be in your mind. Every time it should make you alert in your further plans of caring the patient. Team discussion might be you are the good nurse in the morning who have taken care of the patient very well. Might not be the nurse who is in the night duty can take care of that patient well. So the team discussion, including the doctor, the counselor, including the housekeeping team. Sometimes I see a lot of private or the personal information are shared not with the nurses, not the doctors, but it is discussed with the housekeeping team. So team, as a team, everyone comes together. There is a housekeeping team, one we call them as a Aya, mate. So she told me that, sir, there is a lady in one of a ward. She was telling me that I am unable to sleep at night. Can you help her? So this is a words which you hear from not the family, not the nurse, nor the doctor. It is heard from the other people. What I wanted to say is the team discussion plays an important role. every single person in the team is more important. So discuss among the team and you'll have a good care plan prepared. Like everyone gives you information. So the whole collected information can really help you in managing the patient's symptoms in who are with the infusion pumps or the subcutaneous routes. That's it. And I would like to stop it here and play a small video. It just takes minute time. Just a minute. Just have a look at this. There is a patient. I have added some audio to that too. So one thing we have to tell the family or the patient is we are going to introduce. That's what the nurse has told her. So during the introduction, so when you are just introducing the tube in, it'll be a bit painful, and during the administration of drug, it'll be a little painful again. So just observe the skin area, and these kind of patients come to us all the time. So from a very poor background, they go out to the private hospitals, get treated there, and she is also suffering with one of a different type of cancer and a lot of vomitings and very weak. She has come to the palliative care hospice admission, and for the next few days she was very comfortable and she couldn't take any oral medications. So we tried talking to the family and told her that okay, this is what we can do. So some way the family agreed, and they were ready for this. So this is what I would like to. That's it. Yeah, go ahead, please. I'm up with my session. Thank you.
Thank you, Swarup. Thank you so much for the informative session. I guess there would be questions regarding subcutaneous, because you already said many of you are not aware or not experienced in giving the subcutaneous route. So you can ask questions in terms of how many days, what are the reactions that he might have seen in his experience, or how does the patients and family takes it. You can either type it in the chat session or you can unmute and ask. Does that mean everyone is confident in giving subcutaneous infusion? Do you think it can be given, or it is a better way? Yeah. How to know about the pH of the drug? Swarup, you are muted.
Yeah, it's a good question. Like, so earlier when I had the same question, like how to do that. So I have gone through the drug formulary. I have a drug formulary books available with me. So I have a 6th edition, I think so. So based on that, I go through and just each drug has its own alkaline or acidic preparations form. So just go through the drug formulary book and you'll get a lot of information through that.
Or maybe in palliative care setting, there are specific sets of medications that is commonly given through subcutaneous route. So
Yes.
Unless and until you are experimenting a new drug, usually it is known and been used for years through subcutaneous route.
So how much amount can
how to avoid given? Leak? Yeah.
How much amount of drug can be given? So as I said, it is approximately 1500 is an overload for any kind of patients. If that is a fluids. So when you talk about the injections, there is no such limit through that. But somewhere try to reduce the dose of drugs. Like, the high volume drugs may cause a lot of injuries again. So to prevent that, local inflammations can also happen. So to prevent that, maybe try to mix all these drugs together at a time, and then you can add a normal saline to that. So instead of showing the patient that huge volume of drugs given up through that route, so make it so simpler. And there's another question: how to avoid leakage after subcutaneous injection? So it is most common when you see when there is a disturbances locally. When, if you see, for example, to say you applied it over the upper chest region, and sometimes the patient keep touching it, moving it around. So if that is how the situation, we have to tell the we have to pack it well so that it will not move. And there is any leakage, you have to change the side to the other side. That's it. That's the only thing we can do. So a lot of times when you put a plaster, it gets dry. The lady whom you have seen, she had completely dry skin on that area. So even the plasters may not fix it properly. So we may have to look into that. I see sometimes it has been moving around, hanging when the patient goes out to the washroom and come out. So you have to secure that so that there will be no leakage. How long one butterfly cannula can be used? Approximately, I can say in my experience, one butterfly cannula. Are you talking about the scalp, or is that the cannula? I don't understand the question. So there are two types, like I have shown you. Number one is a butterfly wing needle, which can remain for 5 to 7 days, not more than that. Because as there is a needle inside, sometimes it may leads to damage or injury. So we don't prefer that most of the time, unless in an emergency. We have a cannulas available, so we prefer that instead. So which can be used for more than 8 to 10 days if you are securing it, if you are cleaning it well, looking into the site, and there is no lot of infusion, like a lot of hydrations going on. When you put on the drugs again and again, slowly the superficial areas or that particular area we may develop extravasation. To prevent that, limited quantity of drugs can be given, and it remains for more than 8 to 10 days, which is safer, and it is not painful too. I hope you got that answer there. So how long one butterfly cannula can be used, and how long we can infuse through same cannula in terms of days? Like I said, that it all is individualized, not like when I say that it is used for 8 days, not for all the patients. So based on the skin integrity, if there is a lot of dryness, you may have to change it more frequently, or the patient is delirious or confused, it may not remain for a long time. So there are few circumstances where you may have to change it. So it is not a fixed just like that, but some way based on the patient, you may have to keep changing that. What is the meaning of unit or ml or something else in that? Okay, are you talking about the same infusion pump from that? Okay, so is nothing but the millimeters. So any drug which you wanted to move in a given time, you have to convert it into from the ml form, first from the mg. So all the drugs are in mg form, which are converted into ml, the quantity, and then the ml is converted into speed, which is nothing but the millimeters. So it is mentioned on that So is nothing but when you want some drug to be moved in a given time, you may have to convert it into the speed. How do we calculate the speed? Speed is calculated into miles, kilometers, meters, centimeters, and millimeters. It is a very low dose quantity where it need to be moved in a given time. Very less number, which is calculated in the millimeters. So that is what the millimeters mentioned out there. So another question. So is it less painful than intravenous? I'm sure that it is less painful, but somewhere only thing you have to keep it in mind is be slow, be patient, do not administer just like an IV very fast. So take time, slowly administer the drugs. That's it. That's the only thing. So you have to tell them that whenever you administer large quantity at a time, surely the patient may have a lot of pain. To prevent that, we are going to administer the drug very slow. That's it. There is no hurry. Like, you are not in an emergency to create such situations. It is a routine part where every day, every 4th hourly, the morphine, every 4th hourly, the midazolam, or the continued drugs should be given in a time. So take time and administer. Apart from that, if you have a syringe drive available, that will be more comfortable for the patient for the constant pain control, and there will be no fluctuating levels of sudden breathlessness again or the pain or whatever it is. So it's all continuous process. So there is another question. Yeah, yes, it is true that it affects the peripheral circulation. So there will be slow absorption of the drug when compared to IV. There is a slow access, but somewhere the patient will have a very good response. And like IV cannula, a lot of our patients may develop confusion or irritability, or on sleep they may just the cannula get disconnected, or we may have to change it in the third or fourth day. And unless it is not secured well, or you are contaminating it a lot again. So patients may develop again a lot of infections. To prevent those infections, the subcutaneous route is more safer. Number two, the family is watching everything. You are not sure that all our patients who are in end of life, we are going to put them in our hospital for the long time. If that is how the situation goes on, the family is the first person to take that responsibility. Family has to be taught well, even after going home. There is a patient whose wish was to die at home, who lives in the city, and there is another patient who lives in a remote area. And the city patient who is in the city limits can be provided some home care so that everyone can help. How about the patient who is in the remote areas? There the question comes out. So the patients who are in the remote areas, the family has to be taught more about the good education, how to break the ampules, how to load the medications and give it in time. So we write in their own format. The people can really understand how to administer the medications. That's how we do. So family plays a major role, and they have to learn what we are doing. So how to know that we have placed it in the right position? Very good question. Maybe I have to add that point to this. Thank you for raising that question. So how to know that it is in the right place? How to know that the IV cannula is fixed in a proper way? When you administer medications, there will be no extravasation or the swelling seen in that area. If on IV cannula, if you see the local swelling observed in that areas, it means that you have punctured the vein. As the same, subcutaneous route is something different, and the flow will not be free flow. When you are administering drug and in the subcutaneous, if you feel that the drug is just going in and no swelling, it just means that it is an IV route. Somewhere you are punctured and enter into the IV axis. Our idea is not entering into the IV, but somewhere we have to secure and procure that it is right in the subcutaneous route. So to make it happen, there will be a little swelling. When you introduce little amount of drug into the subcutaneous route, you see little swelling out there. Maybe it may remain for next 5 to 10 minutes and slowly it absorbs into the body. It just means that it is in the right place. We just have to draw and see or check when you are administering medications. If there is a local swelling, that's effective. You're in the right way. Yeah. And next question. IV infusion fluids are slowly. That is, how much can we infuse? As I told you that one fluid, which is 500 ml, can be given for approximately 8 to 10 or 12 hours. One 500 ml can be given for 8 to 10 hours approximately. So based on, see, we are not going to see any change in that. It is not a better hydration, I can say that. But when there is no option and you feel that the patient is being dehydrated in a not a good stage at all, only then we can go for that. And that too, a 500 ml and another 500 ml, that is 1000 ml to approximately 1500 can be given through the subcutaneous route based on the need. We are not going to do such techniques and make the family comfortable. It is not our idea. So it is all about the patient's autonomy and the justice. Are we going to do the justice to them? Only then we can go for that. So common sites over the abdomen is preferred site. Which are the other common sites? Okay, that's a good question again. This is what I was expecting. Very happy about that. So I can say that both upper chest, just below the clavicle, number one, and number two, both sides of the lumbar side, and number three, lateral aspect of a thigh. Not on the anterior side, the lateral aspect of the thigh. As the anterior aspect of a thigh is more painful when you put a cannula, lateral aspect of a thigh is more preferable. And at last but not the least, patients who are a bit confused. There is a patient who is confused, and you put an IV cannula who is on Ryle's tube and the catheter is ready to remove everything which is access to him. But somewhere, patients who are in that stage, most preferably, we fix a cannula in the scapula site, either sides of the scapula, which is more safe and secured. He can't even hold that. It is not so close to him, so he can't even touch it. So the drugs will be more easily administered in that particular area. The family will be panic about keeping it somewhere over the chest, or they may feel that the needle may go in, introduce or enter into the body. So tell them how it is going to be, demonstrate them, show them some pictures how, or any other patients who are already on. If not, if they're scared about what you're doing, they may just run away from your procedures. So explaining the family is more important here. And the next question is common sites over. So which subcutaneous infusions, with subcutaneous infusion, how fast the absorption takes place? Subcutaneous infusion, when you compare to the IV, is more fast acting. Even the morphine trail, injection morphine trail, sometimes we don't get the access of the availability of IV cannula. So we prefer subcutaneous route, which is 5 minutes away apart from that. So if you talk about IV cannula, which works for 3 to 5 minutes, subcutaneous can work for next 5 to 10 minutes. So very little absorption differences is being seen, but not much. So that is what I am telling you. We are not in a hurry to control that symptoms. Overall, we are also looking into the safety of the patient and the family watching you around. So if you do the IV cannula today, they practice the same thing at home tomorrow. If you are doing it today and less education, tomorrow they may depend on the nurse or the doctor to come home and do it. If the patient is in the last stage and at home, and what are we going to achieve in that? So make it more simple and make it more easier for the patient and the family members. I hope you have answered your question. So last question with subcutaneous infusion. That's it. Any other questions? A lot of questions today, madam.
Yeah, because this topic is
Yeah.
always a very hot topic of discussion.
Yes, yes.
Even
yes.
among doctors, they ask a lot of questions, and unbelievability is there when you
Yeah.
say you can give infusions.
Yeah. Thank you.
Any other doubt? I'm so glad that you have brought up a lot of questions.
That was good.
And I will be more glad if you start using the subcutaneous route more commonly than the IV. Once you start using, you will understand the ease of administration and how easy in a home care setting you don't have to put an IV cannula and leave. Then they have to find another nurse or someone, pay them for giving injections every now and then. And keeping the area clean out of infection is very difficult. But with subcutaneous, or for them to understand, it's easier to say like an insulin injection. Insulin injection is given subcutaneously, so everyone would understand. Oh, it is just like the same plane of insulin injection. So then they feel more comfortable, because for everyone, insulin injection is slightly lighter one. So there is a question about conversion and how to convert from ml to mm. I think that purely depends upon what kind of pump or syringe drive that you use. Swarup, you want to answer that question? How to convert from ml to ml? You are muted.
Yeah, so maybe I'll just simply answer to your question very simply. Let us take one injection, like injection morphine. Just think about that. So you wanted the morphine to be given, drug injection to be given for the patient. So who was on 10 mg morphine yesterday and he's in a semi-conscious state today? You have to change it into the other route, like which is a subcutaneous route. So subcutaneous route where you are planning to administer it through the continuous subcutaneous infusion. Just think about the machine there. So let us think about for 12 hours. The patient is on 10 mg oral morphine. It would be converted into the injection form as 5 mg of injection morphine 4th hourly. So let us assume it for 12 hours, which means that 30 mg of, is it 30 mg? Yeah, 30 mg of injection morphine to be given in 12 hours. 30 mg of morphine. Right now I have 3 ampules. Each ampule of morphine carries 10 mg per ml. So that means 3 ml of morphine, ml. See, I'm talking about the ml first. ml, when you load it in, each ml is nothing but 10 mg. So you have loaded it into the syringe 3 ml, which is 30 mg. So first thing we have done is mg has been converted into ml. mg was 30, converted into ml, which is 3 ml. And this 3 ml, when you put it on the syringe, this syringe has to be taken up near to the scale of mm, just like our scale, centimeter scale. You have to bring it close to that and see how much mm has been measured. So this 3 ml is nothing but approximately, you can see some, I can say that 20 mm would be the correct answer. I can't just demonstrate that to you. You just have to bring your syringe up to the scale and mark it in the point, which means that mg is converted into ml is converted into mm. So based on the mm you have got, you have to calculate it into the speed and then convert it, like divide it into 12 hours, and the ratio or the answer you got is a correct flow of the drug into the body. That's all. It would be a bit confusing for you. I may have to demonstrate that. Don't worry about that, because you don't get that. In India, we don't have such portable syringes available. We have brought it from Canada when I have visited last year, and a long time ago from England, we have got those. And there is no such services available in India too. So we have a big power cabled big machineries with us. We call it as an infusion again, but somewhere it is stick to the wall somewhere. The patient has to be on the bed all the time, but it is portable, just like a mobile phone. You can just put it in your pocket and go everywhere. I don't think it is more probably available in our places too. Yeah.
So it's simply it is converting from mg to ml, that you all will be aware, because you give injections. The only thing is ml to mm. That depends on the markings on that machine. The machine will have a scale like things. You just have to bring the syringe close to that scale and then convert how much ml or mm to be given in 12 hours or per hour. Or I don't know whether you some places they have small infusion pumps with PCAs attached. So it depends on machine, what kind of machine that you use. Sometimes you don't have to convert. If you don't have any machine, what we can do is like you can calculate according to drops per minute. When you work in a rural place, you don't have any machines, but you have to give continuous infusion. Then calculating according to the drops per minute, all these medications, that also is possible in a setting where you don't have all these equipments. Thank you so much. That was a very good discussion, question, answers, everything went well. Arun, can we start the presentation for today?
Yes, ma'am. Yes, ma'am. And today's case presentation by Sister Sanda Parvati. Sister Parvati, are you there?
Yes, sir.
Okay.
Shall I start, sir?
Okay, we will share presentation from our end. Okay, you can start.
Thank you, sir. Good afternoon to everyone. My name is Parvati. I am working as a technical team nurse in Sri Venkateswara Institute of Cancer Care and Advanced Research, supported by Tata Trust. Today, I am going to present the small case presentation. My patient details is 65 years of male, diagnosis CA multiple myeloma, presenting complaints, severe low back pain, frequent infections, loss of appetite, weight loss, sleeplessness, constipation. History of illness. A 65 years old man presented with complaints of frequently with low back ache, decreased appetite, decreased weight, and recurrent episodes of fever last 2 years back. Then he had visited different hospitals last 2 months. Finally, a few months back, he was diagnosed as a carcinoma multiple myeloma. Further, he is on chemotherapy with BTD. 10 cycles was completed. Later, he is visited Svikar Hospital for further management. Now, patient is on palliative chemotherapy. On examination findings, temperature 37.6 degrees Celsius, blood pressure 170/80 mmF Hg, pulse 98 beats per minute, respiratory rate 20 breaths per minute, saturation 98 in room air, echo 1, pain 10/5 on numerical rating scale. Treatment and significant investigations are blood and urine investigations were done, CT scan, MRI, PET, bone marrow, and biopsy aspiration. Patient diagnosed as a multiple myeloma. He is on palliative chemotherapy with bortezomib. Right now he is on first cycle bortezomib, and simultaneously zoledronic acid 6 months once he is taking right now. The main psychological aspect of the patient. Patient is 65 years of old man with his wife aged 59 years. He has 2 children, one son aged 35 years, one daughter 32 years. Present patient living with his son. Son only the main source of income. He is doing contract job in private sector. Due to pandemic situation, his son not getting salary regularly. Then patient wants to know about his condition and treatment modalities and cost of the treatment. He feels so sad about his family financial condition right now, and he is feeling he's want to burden about his family members for his treatment expenditures and all. Medications right now, patient taking medications. Lenalidomide 10 mg for 21 days of course. Dexamethasone 40 mg weekly. Tablet Ecosprin 75 mg. Septran twice a day on alternated days. Ultraset for pain, TID. Syrup Cremafin for constipation, 30 ml at night. Tablet Alprazolam, 0.5 mg night for sleeplessness. The main concern for this patient, pain, side effects of treatment, prognosis of disease, financial condition, and family and social issues. Summary: a 65 years old man living with his wife and son diagnosed as CA multiple myeloma in September 2019. He had taken chemotherapy with BTD, botulism, thalidomide, and dexamethasone. 10 cycles are completed. He is on palliative chemotherapy with injection botulism and injection zoledronic acid on 6 months once. At present, patient has pain in while prolonged sitting, loss of appetite, and severe constipation. Discussion points. How can I help my patient to fulfill his desires? How can I explain his poor prognosis to him and family members? How can I help patient and his family financial condition? Thanks to everyone.
Thank you, Sister Parvati. I just wanted to ask, maybe I have missed it. What were his desires? What does he want in terms of desires?
She wants to go devotional places like Kasi, Badrinath, like that places, ma'am. Rameshwaram.
Does he know about his illness, whether he has this cancer? Does he know about that or
He
not
knows,
aware of it?
but not completely know. He know about his cancer condition only, not about poor prognosis, ma'am. His son knows everything. His wife also not aware about his prognosis, ma'am. All family members were aware of he has cancer.
So is there any reason why we have not told the patient about his cancer? Is there any particular reason?
Patient aware about his condition, ma'am, but
Yes,
right,
prognosis.
he's in palliative chemotherapy, ma'am.
Yeah.
Because of her wife only, we are keeping this silence, ma'am. His wife only.
So wife doesn't want to tell the patient about the prognosis, right?
Yes, ma'am.
Okay.
Sridevi, ma'am?
Am I muted? Sorry.
Yes, ma'am, you are muted.
Yeah. So yeah, just read about the using the spikes protocol in terms of talking to the patient regarding the prognosis. Definitely the right way to move on with how to communicate the bad news to the patient. What if we don't tell the patient what will happen? Because this patient doesn't know, wife doesn't want to tell. So what if we don't want to take that effort of breaking bad news? What do you think will happen in this particular patient?
Ma'am, he know, ma'am, about his condition, but before that, he want to see all the places with his wife. Then after that only he wants to know about his condition, ma'am. His son said like that, ma'am. He explained everything in the detailed manner to his son, ma'am. His son knows everything regarding his condition, ma'am. And
So I was asking others, suppose we are not planning to tell the patient, okay, let him go on for the trip and everything. So is there any problem in that? Do you think it is okay or it is not okay? This is for others, not for Sister Parvati. Many people feel that it is not okay to not to tell the patient before he's planning for trips and everything. Sister Parvati, in your setting, are there family meetings to talk to patient? Are nurses allowed to talk to patient and family, or is it someone else talking to them?
no, ma'am.
No means you can't talk to the patient.
Ma'am, I explained the patient, ma'am, but not in detail, ma'am.
Mm.
But we explained everything in his son, ma'am.
No, I'm asking, are nurses allowed to talk to patient and family directly in your setting? Some places they won't let nurses to talk to patients and family. So in your setting, is it okay that you go and talk to them?
Yes, ma'am.
Okay.
We are doing that.
Yeah. I did not understand the last thing. Okay, it is okay not to tell, I think. If he doesn't have ongoing chief complaints or physical problems that needs prompt management, but he has a problem or that there is unrelieved pain a little bit and he wants to travel many places. So that is one thing that we need to plan, whether he is physically able to do all these travels, whether he is aware of his condition, whether they are prepared for suppose he gets sick on the way or he has pain, are they equipped themselves with all these medications and knowledge about the illness? So that is something that is he's facing now. It is not just the pain I'm talking. There are many things that he needs some planning with our help. So I think it would be better to talk to the family and the patient. So one thing that we can start by asking the son and the wife why you want to wait for the trip to happen, or what if something some increase in pain or some kind of tiredness, something happens on the way, how are you going to manage? So they may not be able to manage if they are not prepared, right? So ask why they don't want to talk to the patient. They might be scared whether the patient will go to depression or patient may suicide, patient may become negative, filled with negative thoughts. Usually these are the answers, right? So it's always good to ask the son and the wife why what is preventing you from talking to the patient about his illness, and he has a lot of wishes to travel, and then you need to talk to the treating doctor. Is it okay to do all these travels? We don't know what is the condition, whether there is any anticipating vertebral issues, spinal cord compression or anything. So it's always good to ask the treating doctor, involve the treating doctor also in this conversation, ask whether the patient is able to travel first thing. Then only we can discuss about travel, right? So if
Yes,
the
ma'am.
treating doctor is telling no, then you are in trouble. Now you have to tell the patient you can't travel and why you can't travel. So there comes the stepwise approach of exploring first why they don't want to tell the patient. What are they scared of? What is preventing them from talking to the patient? Is there any opinion regarding that? This is just my way of talking, but it can be different in different situations. It is not hard and fast rule. So in this patient, I would definitely ask the son and wife and explore why they don't want to talk to the patient and address that first. Make them understand the importance of talking to the patient. and then slowly approaching. By that time, background work I will do. I will ask the treating doctor regarding the physical state in terms of traveling, whether he can travel, is it okay, what are the things that you should anticipate, what should be prepared during travel. All those things I will get the background information from the treating doctor before talking to the patient. The one thing that you need to have in your hand is all the medical information, because they keep asking you medical questions. The moment you start communicating with the patient, they ask about prognosis, they ask about the chemotherapy. So you should have all the background information, or if you don't know, it is okay to say, I don't know about all these medications. I will ask the treating doctor or the oncologist or the palliative care doctor to talk to you in this terms. It is okay to say, I don't know, if you don't know further information. Swarup, I would like to hear from you also in this scenario. Swarup, are you there?
Hello, ma'am.
I'm just checking whether Swarup is there or not.
No, ma'am.
Yeah, okay. Maybe some issues. So, is there any other questions regarding how to approach this patient to fulfill his wishes and desires? Financial condition, yeah. So someone has typed in the chat session about contacting some NGOs in terms of helping the patient financially. So first thing I would suggest is, there are so many government schemes and or so many organizations providing support to patients. Many of our patients, or some of us, we don't know what are the schemes available. So what I would do is, like, I'll tell my social worker to ask whether there is any suitable existing schemes for this patient. It is not just about telling that, okay, you go to this place and ask for the scheme. No, we have to help them out. The filling the forms, everything is very difficult for many of our uneducated patients. So our social workers sit with them and make them fill the forms, take photocopies, send it wherever they want to send it. So first thing would be searching whether there are any schemes available for this treatment for this patient, in terms of government schemes or even NGOs, or some local hospital schemes might be there. So explore that first, and then I would ask locally whether there is any organization who can help this patient. And the second thing would be, it's not about giving money for one time or two time. The problem is not going to end there. So if possible, if the patient or even the wife or the son, if they are willing, try to find some vocational rehabilitation, try to give some training in making something or doing some business at home. That is what we follow in Kerala also, that runs successfully, because it is not about providing money once or twice, because the needs will keep increasing and they need some sustainable amount of money to deal with even in future also. It is very effective when you give them some direction, what can be done sitting at home, some trade, making something and selling it. So that is a sustainable income for the family as well. So maybe his wife can do, or his son can do, or he himself can do. So that is one thing that I would suggest in terms of financial condition, rather than just giving a bulk amount of money, which may not actually help more than once. You can't keep giving, right? So they have to have a direction through which they themselves can support. So that is one thing. Any other opinion regarding that, how to help the patient in terms of financial conditions? Many government schemes that we are not aware of. There are many government schemes where these patients don't know how to apply, how to fill in forms, where to give these forms, how to get this money. So that we have to help them to find and to reach that level. So that kind of support will be the first thing I will explore.
You explained everything, ma'am. Right now, patient daughter-in-law making cloth marks, ma'am. By stitching by.
So they now they have some vocation,
Yes,
right? Okay,
Actual
that is
plan
very
is
good.
not budgeted, ma'am. Actual treatment plan is other one, ma'am. Due to his financial condition, his son changed the, I mean, optional injections, ma'am. Right now, his prognosis is poor, ma'am. Because of that only the reason. And we explained about his desires like traveling, ma'am. He is unable to sit prolonged time, and he is also developing the numbness and peripheral neuropathy for this dosage, ma'am, all those things, ma'am. Instead of lot of counseling also, patient not willing to listen anything. I want to go before Daito. I want to see the some devotional places like that, ma'am.
Yeah, so that I think that needs a lot of conversation with the patient every day. How far it is possible, maybe taking a small step initially, just to make himself aware. Like, if you can sit for this much hours, then it is okay. Or if you can travel for short distance, and what is happening in your bone? What if you have a rough journey? What is going to happen? So all these things, it will take time. Maybe he's denying that it is okay. I know that I have illness, but I want to go to these religious places. But talking to him every day, and talking with the family, and make him understand that you are not preventing him from traveling, rather you are helping him from more complications to happen. I know that you might have already done all this, but with one conversation, they may not accept it. Even we may not accept it. So it's important to have almost every day you have to tell the same thing. So at some point, they start understanding. Okay, this may be sometimes I have to rethink. And maybe the another thing that you need to explore is that religious places, he might have some spiritual distress in terms of illness. I might have done some sins, so I want to go to all these places and get rid of all these things. So if you can explore whether that is related to some spiritual or religious beliefs. If so, you can even ask some people who can come and talk to, do some small rituals, so that he gets satisfied. Okay, I am doing this ritual, and it is okay if I don't go there. Also, there are some rituals they do at the local place. So ask why he wants to visit these places. I'm sure it is not for sightseeing. Then he would have chosen some other place, right? Not the religious places. So this is something to do with his religious or spiritual belief. So ask why, whether he is worried about the things he has done in the past, to get rid of some beliefs. So then you can arrange a small thing which can be done in the place where he is. So he gets satisfied. Okay, I've done something, so it is okay.
Okay, ma'am.
Yeah. So there are chats regarding having a family conference and explain his situation or prognosis using spikes, donations, and yeah, many schemes. A lot of schemes are available which we are not aware. So it's really important to talk to each member of the family separately and together. And very importantly, ask why he wants to visit these places. It definitely is something to do with the religious belief that we go to Ganga, take a snan, and come back. Then you are out of your sins. There is no next life, etc. So there may be a lot of beliefs that we need to explore, and if possible, we can do something locally that he is okay to go without going to these places. Any other suggestions from the other participants before we wind up today's sessions? I understand Swarup is not yet back, right, Arun? I can't see him.
No, ma'am. I think
Okay.
sir is not here.
Yeah. So if we are clear about the discussion. So in terms of case discussion, when it comes to case discussion, there is no right or wrong answer that we are suggesting you to do. It is nothing like that. We are just sharing our experience, or all of us together find some way out, and we learn from each other. So there is no, this is to be done like this. There is no right and wrong answers. You might have already done all this. So it is just suggesting from our side, or taking from other participants also, learning from each other. And I hope today's session on subcutaneous injections and infusions are quite useful. And if you start practicing all this, you will understand how easy or how simple it is for the patients and family to manage the patient at home. We have many patients who might be dying, and family really wants to do something at home. Uh, Patient is unable to drink or eat, and they feel quite guilty that patient is not. We are not even giving anything. We are not even taking him to hospital. One subcutaneous infusion makes a lot of change. They feel quite good. Okay, I am managing this at home. I am doing this for my patient, or we are not like simply sitting and watching him die of hunger or thirst. And it is very, very easy to manage at home, easy to remove, no bleeding, nothing. Even if it comes out, it is okay. It's completely fine if even if it comes out. It's not like IV cannula, it is not going to bleed. As Swarup was mentioning, explain them there can be swelling. It is okay because when you put an IV cannula, if there is swelling, it is something quite serious. So they might get worried. Okay, there is a swelling. Is there anything to be done? So you can tell them there may be swelling. Stop it for some time. Reduce the flow. Start reopen it. That's it. It's okay to have swelling. So I always tell them there will be a depot of drug under the skin. It gets absorbed really slowly. That is okay. If the swelling is there, you can either stop it for some time or reduce the flow. That is fine. And it won't bleed. How to administer medications, everything you can teach the caregiver. Even uneducated people in the village areas, they do it really nicely during end of life care. And patients can be at home with all these injectable medications. So I hope you will have the opportunity to try subcutaneous injections and infusions in your setting. And thank you so much for today's presentation. And although Swarup is not there, sorry, there is one. Yeah, so we don't need an infusion pump. I have in Pallium India, I have been using infusion. We have the same equipment that Swarup was showing, syringe driver. I have used it with infusion pump in another setting. And when I went to a rural area to work, there was nothing. So I just used a drip set. I calculated the drops, kept on increasing the drops. You can even use a micro drip set if you want to reduce the volume, either micro drip set or the normal drip set. Both I have used just with this simple drip set, calculate the drops and give it. Thank you so much for your interaction. It was a very interactive session from you all. You asked a lot of questions, and this is how it should be. A lot of questions should come for every session, and thank you so much for that. And Sister Parvati, thank you so much for bringing up a presentation from your side. And you all will have the link in the chat session. Kindly give your feedback, and see you again with another session. Over to you, Arun.
Thank you, ma'am.
Thank you, ma'am.
And Swarup sir is not here. Thanks for Swarup sir also. And thank you, Sister Parvati, for an excellent presentation. And so we are winding up the session, and we have another session on nursing issues on next week, taken by Sister Ayana. And once again, thank you all.
Thank you, sir. Thank you, ma'am. Thanks to everyone for your valuable suggestions.